Good evening. Welcome to the 8th Migraine Masterclass. Good evening if you're in the Middle East or the eastern side of the world, and good afternoon if you are joining us from the western side of the world. It gives me great pleasure to welcome you to tonight's event that is our 8th Migraine Masterclass that is hosted in collaboration between the IVPN NeuroPsychiatry and the Association of Migraine Disorders, and sponsored by our very generous sponsors, Pfizer Middle East. Thank you very much. If you've just joined us, I will just remind you that we will be taking the question and answer in the question and answer box that is right at the bottom of your screen. It gives us great pleasure to welcome you today, and we're looking forward to an amazing event. The event will be two presentations. The first will be by Dr. Lindsay Plato Johnson, and we will take the questions after that first session. And then the second part will be with Dr. Zakaria Amash, and again, we will take the questions for that session after the event. I will start by again welcoming Dr. Plato Johnson, and to present her, I would like to say welcome. Dr. Lindsay Plato Johnson is an accomplished family nurse practitioner with a strong dedication to women's health. Her educational journey includes nurse practitioner training at Johns Hopkins University, followed by a doctoral program at Chatham University. During her time at Chatham, she developed a program that was very special, aimed at delivering cognitive behavioral therapy to patients dealing with chronic pelvic pain via live telehealth sessions. Dr. Plato Johnson's commitment to advancing healthcare access led her to specialize in providing exceptional care through telemedicine. Her pursuit of excellence led to the attainment of a certificate in added qualification in headache medicine and AQH certification, a testament to her ability to deliver expert care to patients grappling with migraine disorders. Actively engaged in the field, she holds esteemed membership within the American Headache Association and serves as a member of the National Headache Foundation Primary Care Guidelines Committee. Beyond her clinical endeavors, Dr. Plato Johnson shares her wealth of knowledge as an esteemed adjunct professor at the University of Southern California. Through this role, she shares her knowledge and expertise with the next generation of healthcare professionals. The subject that she will be sharing with us today is titled Comprehensive Approaches for the Management of Migraine, Acute, Preventive, and Cognitive Behavioral Therapy. Welcome, Dr. Plato Johnson, and the floor is yours.
Thank you so much. I really appreciate that welcome. Give me just a moment to share my slides. Okay, thank you. Good evening, all. I am thrilled to be here. I'm Lindsay Plato Johnson. I'm a family nurse practitioner with added qualification in headache medicine. I live in Maryland in the USA, and I'm thrilled to be speaking with you tonight about the management of migraine using both abortive and preventive pharmacologic techniques, as well as cognitive behavioral therapy. I have no disclosures. During this presentation, the aim of this is to have an overview of the latest treatments and options for migraines, encompassing both acute and preventive care, the pharmacologic treatment, as well as cognitive behavioral therapies. By the end of the session, you will be equipped with the knowledge and tools to optimize your migraine care, tailoring it to the individual patient needs. To introduce a little bit more about migraines, migraine, as you know, is a complex neurological disorder characterized by recurrent throbbing headaches, often accompanied by other symptoms such as nausea, vomiting, and sensitivity to light and sound. The impact of migraines on patients' quality of life and productivity cannot be understated. Chronic migraines can lead to significant disability, socioeconomic burden, and it makes it crucial for healthcare providers to be familiar with the latest approaches in migraine management. Migraines affect over 1 in 10 individuals, more often females, with the most common age in the 30s, which are among the most productive years as it relates to career and family care. Migraine is ranked second after lower back pain worldwide among diseases with respect to years of life lived with a disability. Migraine pathophysiology, to effectively manage migraines, it's essential to understand the underlying pathophysiology of this condition. Migraine headaches are thought to be neurovascular in nature, involving this complex interplay of neuronal and vascular mechanisms. We now know that migraines occur within the context of a predictable phase model involving a prodrome, a potential aura, the headache phase, and finally the postdromal phase. Migraines are a group of headache disorders with distinct clinical presentations. Proper classification is essential for an accurate diagnosis, appropriate treatment selection, and improved patient outcomes. The International Classification of Headache Disorders, ICHD, by the International Headache Society provides a standardized framework for categorizing migraines based on scientific criteria. And understanding the classification enables healthcare providers to differentiate migraines from other headache disorders and allows them to tailor the plans based on the specific migraine subtypes. So here you'll find the definition of a migraine disorder. This requires 5 headache episodes lasting 4 to 72 hours, with the headache having at least 2 of the following characteristics: unilateral location, pulsating quality, moderate or severe pain intensity, and or aggravation by or causing avoidance of routine physical activity. Additionally, during the headache, the patient typically experiences nausea or vomiting and or sensitivity to light or sound. And this is, of course, assuming the exclusion of a secondary headache disorder. The classification can be summarized using the pound mnemonic. This could also be used as a clinical tool for diagnosing and screening for migraines. It includes a 5-question screening tool. The first question is it a pulsating headache? 2 is, does it last between 4 and 72 hours without medication? 3, is it unilateral? 4, is there nausea? And 5, is the headache disabling, meaning that it is disrupting their typical activities? Each of those different questions get 1 point per positive response, and answering yes to 4 or more of the questions has a very high likelihood ratio of having a migraine disorder. One of the challenges in diagnosing migraines is that there are currently no biomarkers that are diagnostic of migraines. Similarly, there are no labs or imaging studies that will diagnose migraines. The entire diagnosis is based on the patient history and their presentation. And I put a quote there at the bottom, just as a reminder, from Sir William Osler, who says, "Listen to your patient, he is telling you the diagnosis." The approach to treatment then has to be individualized. So once a migraine disorder is diagnosed, the next challenge is how to approach it. This is not a one-size-fits-all situation, but rather the treatment needs to be individualized based on the patient's characteristics. With the model of a shared decision-making model, both the clinician and the patient are working together to develop a treatment plan that will be most effective and appropriate. This allows the patient to take into consideration factors that may be important to them, such as side effects, medication cost, and while still allowing the clinician to guide them based on the best practice. The first step in treatment is to effectively stop a migraine before it progresses and becomes disabling. And to do this, it requires an early intervention with an effective abortive medication. For the sake of this presentation, I'm focusing on treatments that would be used within an outpatient setting. Within the inpatient or emergency department settings, other modalities may be commonly employed. Here are the most commonly prescribed categories of medication for acute or abortive migraine medications. The first is NSAIDs, or non-steroidal anti-inflammatory drugs. Next are triptans, followed by gepants, followed by the new ditan class, combination therapies, ergots, and devices. And of course, if somebody is experiencing nausea or vomiting along with their migraine, it's recommended to prescribe an antiemetic such as ondansetron or metoclopramide. This is not only to alleviate their nausea, but it also enables them to take an oral medication that could be more effectively metabolized with the absence of vomiting. So let's talk about each option individually. So the first one I want to speak about is typically available without a prescription or over the counter. The main action of nonsteroidal anti-inflammatory drugs or NSAIDs is blocking the production of prostaglandins via the inhibition of cyclooxygenase. This helps reduce inflammation and pain. I will note that NSAIDs, as well as acetaminophen or paracetamol, are often used in combination treatments. Sometimes these combination treatments can contain butalbital, which may increase the risk of medication overuse headaches. And we'll touch on that in just a few slides. Triptans are among the most commonly prescribed medications for migraines. They bind to serotonin receptors in the brain, which result in a decrease in the intensity and the duration of migraine symptoms, such as headache, nausea, and sensitivity to light and sound. GPANs are more often used lately. They have a calcitonin gene-related peptide, or CGRP. It's a protein that's responsible for transmitting pain signals along the nerves, contributing to the generation of the headache pain linked to migraines. GPANs function by obstructing the binding of CGRP to its receptor, thereby preventing the initiation of these pain signals. This is a newer medication that has a lot of promise. Dr. Zachariah is going to be actually speaking a little bit more on this next. Ditans are a newer class of drug, and they work by blocking a specific serotonin receptor, specifically the 5-HT1F receptor. And this class offers an alternative for individuals that may not tolerate or respond well to triptans. Ergots refer to a class of drugs that's derived from the ergot fungus with vasoconstrictive properties that could help alleviate migraines by narrowing blood vessels and reducing that blood flow. The historical use of ergot derivatives for migraines dates back many years, with ergotamine being one of the most early treatments known for migraines. However, advancements in medication have led to development of more targeted and effective migraine therapies that reduce the reliance on ergot-based medications due to some of the potential side effects and limitations. There are also a variety of devices available that can be used for migraines that provide relief by interrupting the migraine processes through various mechanisms. This also includes cold packs, which I did not list up there, that can help by constricting the blood vessels, and a lot of patients find some good relief from those. When talking about as-needed treatments for migraines, it's also important to mention the occurrence of medication overuse headaches. The definition is noted on the slide above. These headaches occur when a patient is consistently and excessively using acute migraine medications such as triptans, combination treatments, pain relievers, opioids, anything for an extended period of time. This overuse can lead to a paradoxical increase in headache frequency and severity, often turning into a chronic headache condition that's more difficult to manage. The prevalence in the general population is 0.5 to 2.6%, though it has been reported higher in Iran at 4.6%. The prevalence is substantially higher in those that have chronic daily headaches. It should be noted, though, and cautioned that not all individuals that frequently use as-needed medications develop medication overuse headaches, and that there are some intrinsic factors that are associated with the risk of its development. Beyond the obvious risk of overusing as-needed medications, smoking and sedentary lifestyle also increase this risk. It usually, but not invariably, resolves after the overuse has stopped. The use of preventive medication greatly reduces the need for as-needed medications and should be considered, particularly in patients that are at risk for medication overuse headaches, as well as those experiencing more than 4 to 6 migraines per month. Preventive medications for migraines are recommended for individuals who experience frequent and severe migraine attacks that significantly impair their quality of life and daily functioning. These medications are considered when acute treatment alone is no longer sufficient, or when the use is limited due to frequent or potential side effects. Our previous toolbox consisted of drugs that were typically intended for other conditions, such as depression, high blood pressure, and seizure disorders. Recent research has shed light on the role of the trigeminal vascular system and CGRP in migraine pathophysiology, leading to the development of very targeted therapies. Preventive medications vary from daily or oral medications to injections to infusions. They may take several weeks to months to show the full effect. And so it really is important to have the patient on board and receiving adequate patient education about what to expect. Preventive medications, the goal of these is to reduce the frequency, severity, and duration of migraine attacks, ultimately improving the patient's quality of life. The first one I want to speak with is about the tricyclic antidepressants, or TCAs. These are a class of medications that have been used for migraine prevention. While not specifically designed for migraines, TCAs like amitriptyline and nortriptyline have demonstrated effectiveness at reducing the frequency and severity of migraine attacks. They work by affecting certain neurotransmitters in the brain and modulating the pain perception. Due to their effective sedation, one of their side effects is sedation, they're sometimes helpful when disrupted sleep is a component of a trigger or a side effect of the patient's migraines. Selective serotonin reuptake inhibitors, or SSRIs, are another class of medications that have been explored for migraine prevention. Certain SSRIs, such as escitalopram and sertraline, can help in reducing the frequency and intensity of migraine attacks. Additionally, they help to address the comorbid depression and anxiety, which we know could worsen migraines. Beta blockers are very commonly used for migraine prevention. These drugs, such as propranolol and metoprolol, were originally developed to treat cardiovascular conditions, but they have shown efficacy in reducing the frequency and severity of migraine attacks. Beta blockers work by blocking the effects of adrenaline, which can help prevent the blood vessel dilation and decrease the sensitivity of the pain pathways. Angiotensin receptor blockers, or ARBs, are a class of medication primarily used to treat hypertension. However, some ARBs, such as candesartan and valsartan, have been investigated for their potential use in migraine treatment. These medications work by blocking the effect of angiotensin, which plays a role in regulating blood pressure and blood vessel constriction. While not a typical first-line option, it may be considered in somebody who has comorbid hypertension. And we'll talk about this a few slides down, but one of the goals of treatment is to try to make sure that you are simplifying the treatment. So if somebody has hypertension, consider a beta blocker or an ARB to treat that will also treat their migraine, because that would be less pill burden for them, and it'll be a little bit easier to increase adherence to the treatment plan. Anti-seizure medications, also known as anti-epileptic drugs, or AEDs, have shown effectiveness at reducing frequency and severity of migraine attacks. Some AEDs that are commonly used include topiramate, valproate, and gabapentin. In general, these medications work by stabilizing abnormal electrical activity in the brain and modulating the neurotransmitters that are involved in pain transmission. Calcitonin gene-related peptide monoclonal antibodies represent targeted migraine prevention, and this has medications specifically designed for migraine prevention. These work by blocking the effects of CGRP or its receptors, and by doing so, it helps reduce the frequency and severity of migraine attacks. These medications are generally well tolerated and have shown significant efficacy in individuals with chronic and episodic migraines who have not responded to other preventive treatments. Onabotulinum toxin A, originally known for its cosmetic applications, has been approved for migraine prevention since 2010 in the US. This followed observations that individuals that were receiving these injections for cosmetic purposes actually experienced fewer migraines. And this is still quite often used. It requires an injection every 3 to 6 months, depending on how the patient is tolerating. Medical devices can also be part of the toolbox. It's an innovative non-pharmacologic alternative to manage migraines. As I mentioned previously, successful treatment of migraines is often not just a one-size-fits-all. You also often have to use a combination of treatments to find what works best for the patient. And medical devices are really nice to include within a treatment plan. Nutraceuticals are natural products that are used for potential health benefits, and several nutraceuticals have been explored for their potential in migraine prevention. Magnesium supplements show promise in reducing migraine frequency, as magnesium plays a role in regulating neurotransmitters and blood vessel tone. Coenzyme Q10 or CoQ10 is another nutraceutical that has been studied for its potential to decrease the frequency and severity of migraines due to its possible role in cellular energy production and antioxidant activity. Additionally, riboflavin or vitamin B2 supplementation has demonstrated some effectiveness in reducing the frequency of migraines, and this may be due to its involvement in energy metabolism. There are also non-pharmacologic approaches, including trigger avoidance. Now, this could be a bit controversial, and we'll talk a little bit about that in just a moment, but it may be effective for some individuals and empowers that individual to be more engaged in their care. To best evaluate and identify triggers, it's recommended that the patient keeps a diary and identify anything that has preempted their migraine. Some examples of migraine triggers include increased stress, which may be related to a heightened sensitivity and changes in cortical excitability. This may also contribute to the transition of an episodic migraine to a chronic migraine. The perception of migraine burden is also heightened during high stress situations. With fluctuations in hormonal changes, specifically changes in estrogen during the menstrual cycle and perimenopause, this could all increase the likelihood of migraine episodes. Most women experience migraines typically will have a resolution within 5 years of their final menstrual period. So certainly something to look forward to after hot flashes. There are some foods and beverages such as alcohol, caffeine, aged cheeses, chocolates that could trigger migraines in some. So the big question remains whether the craving that preempted that person eating chocolate or consuming these substances was a premonitory symptom of a migraine. So perhaps something that cued that they were going to have a migraine made them want chocolate. They had chocolate and then had a migraine, but that migraine was potentially coming either way. Similarly, though, skipping meals and dehydration could trigger migraines. But as I mentioned before, nausea and vomiting are a pretty common component of a premonitory symptom of a migraine. And so somebody may experience a decrease in their appetite leading up to that migraine. Non-pharmacologic therapies offer valuable alternatives for managing migraines. Acupuncture has gained attention for its potential to alleviate migraine symptoms and reduce their frequency, though some of the data is limited. Relaxation therapy, which includes techniques such as deep breathing and progressive muscle relaxation, can help manage stress and tension that often trigger migraines. Engaging in regular exercise has shown promise in managing migraines and preventing migraines by improving the overall health and reducing stress. It is, however, important that you find an exercise routine that best suits the patient and does not trigger migraines, as some exercise routines can trigger migraines. Cognitive behavioral therapy is a psychological approach that helps individuals identify and manage triggers, thoughts, behaviors related to migraines. We'll be covering CBT a bit more in depth. While medications play a significant role in managing migraines, a comprehensive approach to migraine management involves addressing the psychological factors as well. Altering negative thought patterns, emotions, and behaviors through cognitive behavior therapy, or CBT, can help migraines in multiple different ways. The primary aspect of CBT is identifying and addressing negative thought patterns and emotions such as worry, fear, and anxiety, as this can contribute to onset and exacerbation of migraines. Throughout the program, stress management techniques and coping strategies are reinforced, and this helps to empower the patient and have them more engaged and involved in their therapy program. It is known that negative emotions and belief about pain can amplify the perception of pain, particularly when some of the thoughts are catastrophic levels of thinking. CBT aims to reshape these beliefs and emotions by teaching individuals to reinterpret and reframe their pain experience. By altering how individuals perceive and react to pain, CBT can lead to a reduction in perceived intensity of migraines and improve the overall pain tolerance. That this aspect has been found to reduce the disability associated with migraines. Negative thought patterns can also impact lifestyle choices such as sleep patterns, diet, and exercise, which in turn influences migraine frequency and severity. So if somebody feels that being active or going outside is going to trigger their migraine, they are more likely to avoid that activity, or they may avoid going outside. And this may continue to add on to the level of disability they're experiencing due to the migraine disorder. CBT helps to encourage these positive changes in their lifestyle, promoting all these physical activities and regular sleep. And those changes help with a better overall well-being and potentially lead to fewer headaches. And I did note there that this serves as a valuable complement to acute and preventive treatment. In many cases, this is not going to replace the treatment for the patient, but it does help as part of that toolbox. So how does CBT work? CBT works, it involves cognitive restructuring, behavioral activation, and relaxation techniques. And to put this simply, by changing our thought patterns about a situation, we're able to alter our behaviors into a more healing pattern. So the ABCs to work on the cognitive restructuring of migraines, the ABCs of cognitive behavioral therapy include the activating event, the belief that is assigned to that event, and the consequence of that belief. So allow me to explain this a little bit further using a typical type of scenario. So the patient may wake up with an impending migraine. Perhaps they're having some maybe an aura, or perhaps they're having some of the premonitory symptoms that they are familiar with that lead towards a migraine. And so this is their activating event. The belief about the experience, however, may take on a catastrophic tone. So they may think, well, now my whole day is going to be ruined. I'm not going to be able to take my son to sports tonight. It's going to be a really rough day. I'm going to have to call out of work, et cetera, et cetera. And the consequence of this belief leads to increased stress and anxiety, because you have to start thinking of second plans and, oh, if I take off of work, it's a busy day, perhaps even canceling plans for those days. And that shifted focus makes it harder for somebody to care for themselves and may not accurately reflect reality, since an effective abortive medication taken early in the process may be effective for them. So while we are working on changing that activating event, right, through using that abortive treatment, through using preventive care, the patient can meanwhile alter their belief about that experience, which changes the consequence as noted here. And so in this situation, they have the same activating event, but instead they identify perhaps that they're having a negative thought about it and change it. They reframe it. They tell themselves, I've experienced this before. I should take medication now at the first sign of a migraine, and that'll be most effective. I should be able to go on with the rest of my day. That consequence, that belief, leads to them taking that medication, feeling confident in its efficacy, and be able to recover quickly from a migraine while still experiencing fewer negative thoughts and, of course, less guilt. So there are many benefits of CBT for migraines as well as for other conditions. It provides patients with long-term coping strategies, even long after the therapy has been completed. They feel empowered and have control over their condition and are better able to actively participate in migraine management. Prior to CBT, a patient may feel out of control. They feel that the migraine is controlling their life. And by having them take CBT and go through CBT, they're better able to take charge of their life and know that they have options, and they're able to be more actively engaged. CBT could lead to a reduction in medication overuse and the reliance on acute pain medications, which can contribute to medication overuse headaches. CBT is generally well tolerated, doesn't have many side effects, and so it's a valuable adjunct or alternative to pharmacologic therapy. I also noted that it helps to address any comorbid psychological conditions, such as anxiety or depression. So CBT for migraines typically involves a series of about 8 to 12 structured sessions. CBT is unlike a typical therapy. They aren't really exploring somebody's childhood. They're not really doing a psychoanalysis of the patient. They're talking more about the here and now, and it's very structured and patient-led. This is done by somebody who is either trained to deliver CBT and specializes in the treatment of headaches or chronic pain. Very often, this is going to be a therapist or a psychologist, but I do feel it's important that it is somebody that typically manages chronic pain disorders. These sessions could be performed in person. It could be done via telehealth or in a group setting, really depending on the patient's preference and, of course, the availability of those resources. So the patient should expect that during the CBT sessions, it begins with an assessment of their headache history, their triggers, and their beliefs, and their emotional responses to pain. When I ran CBT sessions for patients for chronic pain related to pelvic pain, one of the first questions I asked was, what is pain to them? What does that word mean to them? And it was very interesting to hear the different responses. And you get an idea, a glimpse into what sort of belief system is assigned to that experience. It should be noted that CBT requires full involvement and commitment on the patient's part. This is not something that they could half-heartedly take part in, and it does require work. I let them know the first day, there's homework with this, and this will require a lot of active participation. They're taught to identify and challenge negative thought patterns, develop problem-solving skills, and enhance stress management techniques, such as relaxation techniques. This could be very effective for migraines, and research studies have shown that CBT can be effective treatment, particularly for patients that have frequent chronic migraine attacks. It is worth mentioning, though, that some of the studies have had mixed results in the efficacy, particularly when comparing it to other treatment modalities. Nonetheless, it can be a helpful part of the comprehensive management strategy for patients with medication overuse headaches, and CBT has been found to reduce the frequency, duration, and intensity of migraine attacks in some individuals. I do want to touch on, just take a brief moment to talk about migraines in special populations. It is important to note that the management may differ in these different special populations. While CBT is often used and can be fairly universal, medication selection and treatment modality selection may differ based on the patient's age and the risk of side effects. For example, we might not consider perhaps a highly sedating medication in somebody that is elderly and at risk for a fall. Similarly, we don't use many medications that are very sedating in children either. Menstrual migraines in particular require a unique management strategy due to its association with hormonal fluctuations. So hormone therapy, including estrogen supplementation or birth control pills, may be considered for prevention, but caution must be used if the person experiences migraines with aura, such as visual changes, as this may increase the risk of stroke when combined with hormonal therapy. Tracking menstrual cycles and identifying triggers can help tailor those management strategies. In some patients, I suggest that they take a medication prior to their menstrual cycle starting, if it's a predictable cycle. In pregnancy and lactation, caution must be used in any medication that may spread to the fetus or through breast milk. In each of these specialized populations, personalized care is absolutely essential. Like I mentioned earlier, I wanted to note that adherence plays a very major role in migraine management. Adherence refers to the extent to which patients follow the recommended treatment regimen. And consistent adherence ensures optimal effectiveness of acute and preventive medications. Things like skipping doses or disregarding instructions could compromise treatment outcomes and make it so that the patient may not be as successful in managing their migraines. So we want to talk about overcoming some of the barriers to adherence. So what are some of these barriers? Some of these are lifestyle factors. Perhaps transportation to get to the appointment is an issue. Perhaps they work a different shift or a split shift. And so taking their medication at the same time daily has been a challenge. It may just be forgetfulness, or maybe the side effects are intolerable, or they just didn't have motivation. They've tried lots of medications so far. This is particularly true for my patients that have had migraines for most of their life, and they've kind of been treatment fatigued at this point. Now we have lots of great new treatments, but they are a little fatigued by trying a lot of new things. Some of the strategies to overcome barriers include patient education. So educating them about the adherence and potential benefits, assisting them in using alarms, calendars, and smartphone apps that may help with prompting the medication intake. As a provider, you want to make every attempt to simplify and streamline their treatment so that it's a little bit more manageable for them to take. And when it's appropriate, particularly in the pediatric population, you want to incorporate family to offer some support in this process. The benefits of regular follow-up are very essential, especially early on in the treatment process for migraines. Regularly scheduled follow-ups with a clinician allows for continuous monitoring of treatment progress and allows people to make necessary changes to tailor the treatment to the individual's response and their evolving need. Regular follow-up prevents relapses by helping the person identify any potential relapse triggers and address them before they escalate. So even once somebody is doing well, they're on a preventive medication, they're having very few breakthrough headaches, it's still important to follow up with them so that if you do see those headache frequencies starting to increase, you can kind of get ahead of it and treat it before it becomes out of control. This is why I still promote that a patient should keep a headache diary or keep track in some way of the headaches that they're experiencing. There's fantastic smartphone apps that they could use, and that helps to allow them to see what patterns are available. Much of the insured follow-up and adherence is based on empowering the patient and provider relationship. This includes involving the patient in their care using a shared decision-making model, using open communication to express concerns, asking questions, and receiving guidance, and continuous patient education that helps empower the patients with knowledge about their condition, treatment options, and some self-management techniques. And one cannot talk about migraine management without acknowledging the significant psychological impact that occurs with migraine disorders. As I mentioned earlier, migraine disorders are among the most disabling conditions globally. Migraine experiences can be influenced by psychological factors such as stress, anxiety, and depression. And this starts to become a self-fulfilling prophecy, a self-fulfilling machine, because the more stress they experience related to the condition, the more likely they are to experience migraine triggers. And it can be a very stressful experience. Looking at the migraine phase model, there are multiple days involved. It's not just the headache. It involves this prodromal phase, the premonitory symptoms. It involves an aura that can be disruptive to their life. And then after that, it has the migraine hangover that they're experiencing for possibly days afterwards as they recover from having the headache experience. CBT helps to equip individuals with strategies to manage pain perception and cope with triggers, potentially reducing the intensity of migraines, thus breaking this pain cycle. It also teaches them adaptive coping mechanisms, enhancing the ability to manage pain and stress effectively. Ultimately, the most effective treatment for migraine disorders is not going to be that one size fits all, but combining approaches will lead to the most effective treatment overall. Treatment plans should be individualized and created with the patient's input on their preferences and their needs. Acute treatments provide immediate relief, while preventive medications aim for long-term management. CBT complements medical interventions and by addressing some of the psychological factors that contribute to the migraines. And a collaborative care approach will help involve the patient. It improves patient outcomes and improves their quality of life. There is no greater time than now to be engaged in migraine therapy. There's new targeted therapies that are coming out regularly, and it allows for a greater customization of treatment for the patient. It's so nice to be able to go and to see a patient and now have the confidence that you're going to be able to help them, because there's so many options available, and you know that you could talk to the patient about these options and find something that works best for them. With the use of a collaborative approach, incorporating acute and preventive strategies, patient education, along with cognitive behavioral therapy, you have a comprehensive toolkit to successfully manage the patient's migraine and allow them to gain back their life. Thank you. Here's my references. And this is a migraine resource kit that is available for healthcare providers.
Can you hear me?
Yes, I can hear you now.
Yeah, sorry about that. So thank you very much for this very, very interesting presentation. I will start with a couple of questions, and they're around CBT or cognitive behavioral therapy. So we do have a big shortage in therapists and psychologists today in most of the world, not only North America. Do you provide this yourself? Do you have a team? What is the setup in your practice for CBT?
So that's a great question. And CBT, while it is typically performed by mental health professionals, it doesn't involve a psychoanalysis of the patient. You're not really diving into some of the things that require some specialized training. There are guides that you could follow step by step that walk somebody through CBT. This could be performed by a trained nurse, a trained registered nurse that is able to deliver the cognitive behavior therapy. There are different training programs that they could follow, and there's a variety of ways that this could be offered. It could be offered synchronously. So you're meeting with a group of patients, and you could do this via Zoom. You could do it in one room. It could also be offered asynchronously, so patient-led. So they go through an app or a program and kind of go step by step throughout that process. So there are options.
And one-on-one versus group. What is your preference? What works best?
It depends on the patient. It really depends on the patient. I don't think there's necessarily one over the other that's better. Sometimes it's nice when people are talking to other individuals and they realize they're not alone. There's other people out there that are experiencing the same thing. There's other people that are having the same struggles. There's other, they're talking to another mom that had to miss their child's play practice because of a migraine. And so it's kind of that camaraderie that they're able to have with the group therapy. That said, some people prefer a more private one-on-one setting, and that's okay too.
And I have a question in the Q&A section. Dr. Plato-Johnson, do you find CBT is generally well received by your patients? Do they brush it off, or are they excited to try it?
It's a mix. It really depends on the patient's reception, because one of the issues with migraines is, unfortunately, many of these patients have been brushed off for many years. They've seen their primary care provider. They say, oh, it's fine. Just be less stressed. Here you go. And, this is all in your head. And so sometimes you have to be very cautious in explaining that, look, this doesn't mean that this is just self-created. This is just a tool that's going to help you manage your migraines. It's going to help you identify what is helpful and what's not helpful. And sometimes I just break it down that simply. So if they have a negative thought, it's not, is that going to make a migraine? Was that a helpful thought? Or was that a not helpful thought? If it's a not helpful thought, what can we change it to that's going to be helpful?
And I have a question also, does the CBT sometime not include medication use? Do you have patients that only have CBT?
No. Usually when they're at that point, they're going to be on a combination of treatments. At the very least, as needed medication.
And CBT is a coping mechanism more than anything else. It helps them live a better quality of life or have a better quality of life versus not having that, because it just empowers them and gives them the chance to manage their condition better. But there was one question that was around treatment. Does it treat? That's not actually a treatment modality, is it?
I wouldn't say it's a treatment modality. I would never recommend it as the sole treatment ever. It is a complement to a well planned out abortive and preventive medication plan. And it's something that helps some patients. Not all patients have negative thought patterns when it comes to their migraines. Some of them just have migraines, and to them it's a migraine. There's not a dysfunctional belief that is necessarily assigned to it. For patients that have more of the negative thought patterns, the catastrophic thinking, those are the patients that are going to benefit the most.
I have a few questions.
Sorry, can I interrupt?
Yes.
I have one comment.
Yes.
I just want to add something very important. I really encourage everyone to combine cognitive behavioral therapy or any psychological support with the medicine.
Yes.
The psychological part of migraine, whatever medicine you are taking, if we don't work on the psychological part by decreasing anxiety or black thought or whatever it's having, medicine is not going to work alone. We have to make it clear, even with the new medicine that we are having, the anxiety part has to be treated, and the psychological support is extremely important.
Well,
This is
then
what I wanted to add.
Then my question is, how easy is it for practitioners to learn this? Is it a skill that can be learned easily? You said there are courses. You don't need to become a psychotherapist. You don't need to analyze. All you need to do is learn skills that you can impart on to your patients, or that you can actually share with your patients. Is this something that can be done in a short course? Is this something, what do you think? If I wanted to provide CBT for my patients, what would you recommend I do?
So that's a great question. It doesn't require intensive training. Like I mentioned, you could have somebody who is not a direct clinician, like a nurse, that is able to get trained to provide this service. And so the way CBT is that it's a very structured program. So it's typically just that 8 to 12 sessions, and they're very clear, very structured programs. And so just there's lots of training programs that I've seen online that are synchronous, that are asynchronous, and all of those would be helpful. I would encourage, though, that if you're seeking out training, that you're looking specifically for training for chronic pain conditions. CBT can be used for a lot of different conditions. It's effective for anxiety, depression, insomnia, hot flashes, lots of different conditions. But when you're looking specifically at pain conditions, it is helpful to get trained directly in that.
Then the next question, you talked about treatment fatigue, especially with people who do have or who have tried many treatments and many modalities to control their condition. Do you feel that CBT also helps with them trying on and getting the best results of the new medications?
Absolutely, because that's a negative thought right there, is this medication isn't going to help me. I've tried so many medications before, this is not going to help me. But that's right there, a negative thought that could be addressed. But really, the most important key in that is actually going to be that provider-patient relationship. And that's why it's really key to have the patient involved in their care and to develop a trusting relationship where they trust that you are going to help them find a path that's going to be in their best interest, and it's going to be something that they're comfortable with. And that's ultimately what's going to allow the patient to be willing to try a new medication.
Dr. Plater-Johnson, the question I have is, do you also manage migraine in children in your practice, or do they go to a pediatric practitioner?
Pediatric.
Okay, then the next question is for your elderly patient with comorbidities, what in your opinion is the best option?
So for them, the CGRP MABs are fantastic options. They really don't have many interactions. One of the limitations, and this probably is not a global issue, but it is more of a US issue, is that our insurance companies require that they have failed multiple other treatments before they try a CGRP MAB. So that's usually one of the barriers.
My question to you is around supplements. Tell us about how you incorporate supplements and nutraceuticals in your practice.
So I am very cautious with recommending supplements due to just some of the regulation challenges. Magnesium, CoQ10, riboflavin, those are the three that I'll usually stick with. Feverfew is one that was used previously. There are some concerns about some of the side effects. And so I do typically discourage that as an option. But otherwise, I do think that they can complement therapy.
And do you have a recommendation for, I have a question in the Q&A asking about what kind of magnesium do you recommend? Do you have a preferred formulation or salt?
I don't. It goes a little bit by patient tolerance, because some patients just really, the 400 milligrams is typically the recommended dose. Some of them really experience some significant gastrointestinal side effects. And so it really goes based on the patient's tolerance and to see how they're doing. Sometimes we have to just start with a really low dose.
And a question around melatonin. What about melatonin?
I don't typically use melatonin. I know that in some places it's prescription only. In the US, it's over the counter. Don't usually use melatonin for sleep. So it's not a supplement that I typically use. I'm not opposed to patients using it. It's just not one that I usually will recommend.
Okay. And omega-3 diets, special diets, do you talk to your patients about diets or omega-3 rich diets? Or I get the question all the time from my patients, is keto good? Intermittent fasting is now the biggest one for all my patients. Everybody wants to be on intermittent fasting. What is your view on these options?
I'm really big on the well-rounded, just a general healthy diet, not a fad diet. Yes, intermittent fasting, it's fantastic for a lot of things. It's fantastic for weight loss. It's fantastic for your cholesterol, but it is not fantastic for migraines. Your body, you have to respond to what your body is telling you. And I would say most of my patients that try intermittent fasting are experiencing headaches towards the end of their fasting period. And that typically could be prevented with a little different shift in their diets. I also ask that they try to track their triggers, but I don't want them to get so obsessed over their triggers, because people could really go down a path, and I don't want them to follow a highly restrictive diet, because there's not really a lot of evidence to support following a restrictive diet for migraines.
Well, I think one of the things that we also see with CBT is, instead of avoiding your triggers, is embracing things that actually make you better or feel better. Instead of saying, I'm not going to be having coffee, is I'm going to be having a juice that has anti-inflammatory, that is green, that is like enforcing positive habits versus avoidance. And I'm not going to do this, I'm not going to do this, because that's an extra pressure on our patients. And it does make it much more challenging to live with a condition if I'm not able to do things, versus I'm going to embrace more healthy lifestyle options. I find that it works better, and I get better acceptance from my patients, because I have these patients that come in and say, I've eliminated everything from my diet, I still get a migraine.
Exactly. Well, yes, that's what I don't want to see. I don't want to see somebody that's eliminated, they're only eating, a cracker every few hours, and that's all they can tolerate. That's just not that's not healthy. I want them to embrace healthy foods that do improve their health, and maybe recognize better that, hey, drinking a glass of water actually made me feel better.
I have a question around D3 and K2. Yeah, I mean, we supplement in North America, everybody supplements because we don't have enough, at least in Canada. I know that we supplement, everybody gets a vitamin D supplement. Yeah. What is the situation in your practice? What is the recommendation?
I would say a lot of my patients are women, and so many of them do take vitamin D, typically not related to their migraines, but more related to overall bone health, or they just are fearing that they don't get enough sunlight, and so they take extra vitamin D. But aside from that, it's not necessarily something that I push. I really am big on trying to get a lot of these vitamins from what you're eating and your lifestyle management, as opposed to taking supplements.
And I have another question that is interesting as well. Menstrual migraine. You touched on that, special population, menstrual migraine. Do you recommend any prevention? Do you, how do you help people living with menstrual or migraine?
Absolutely. So patients that don't have an aura with their migraine, they just have migraine without aura, and it occurs during the menstrual cycle. Easy to manage because you just prevent the menstrual cycle. So putting them on a combination hormonal contraception typically will wipe that out, so long as they're taking it continuously. So they're not having that fluctuation in their hormones. It is a little bit trickier when you have somebody that has a migraine with aura. While sometimes a progestin only pill is helpful, most of the time it's that estrogen that's causing the issue. For them, I like to recommend, if they have predictable cycles or they have some of those premonitory symptoms, to take a long-acting triptan, or perhaps take a long-acting GPANT, something that'll help last over the next few days.
And what about no interruption in their oral contraceptive pill, or try and give continuous hormonal replacement therapy kind of? Is that something that you initiate, or is this something that their gynecologist or family doctor initiate?
I would initiate that. That's without a problem, especially because I feel really comfortable being able to identify whether or not they have an aura, and determining what method would be best.
So the aura and oral contraceptive, I'm just going to remind our audience today that there is enough proof that estrogen for people living with migraine with aura, there's an increased risk of stroke. And we try to avoid higher doses, but at lower doses, it's possibly safe. Yes. Do you avoid it altogether, or do you go for a combination with low estrogen? How do you practice? How do you do this?
In the US, I follow the CDC guidelines, and they recommend against combination therapy. My suspicion, though, is, like you mentioned, those lower dose combination pills, like those with 10 micrograms of estrogen, just a little sprinkle of estrogen. I'm really curious to see how the future recommendations come out, as there are many people that are prescribing low dose birth control pills with migraines with aura.
Okay. I think we've come to the end of tonight's question and answer and your amazing presentation. Thank you very much for joining us. I'm sure our audience enjoyed this as much as I did, and we would love to have you again. Thank you very much. We hope you enjoy the rest of your day, and it has been a pleasure having you join us tonight. Thank you very much.
Thanks so much. Bye-bye.
Okay, so thank you very much. I know that there's a lot of questions that are still in the Q&A. Unfortunately, we cannot take all of them, but please continue to join us on future events, and we're hoping that we will be able to take more questions. Well, I think we've come to the next part, and it gives me great pleasure to introduce Dr. Zakaria Ammash. I have received Dr. Ammash's bio, and my first note on this is that this does not describe the amazing speaker that we have today. I've known Dr. Ammash for years. He's been one of the biggest names and authorities on neurology in the Middle East. It gives me great pleasure to introduce him today. And again, I think that the bio that I'm going to read is not going to give him enough credit for the amazing work he's been doing in our region and around the world. So Dr. Ammash is currently a senior consultant neurologist at Sheikh Shakhbout's Medical City in Abu Dhabi. He is an American board certified neurologist with a special expertise in movement disorder and Parkinson's. He obtained his medical doctor degree from the University of Paul Sabatier in France. He did his residency at the University of Iowa Hospital and Clinics, and his fellowship in movement disorders at the same hospital. He has been the chair of neurology department at Clemenceau Medical Center for the last 15 years, and just recently moved to Sheikh Shakhbout's Medical City in Abu Dhabi as a senior consultant neurologist. Dr. Ammash is a member of several regional and international neurological societies, and his contribution to people's lives and to education in the Middle East, again, I think I'm not giving you enough credit and a proper introduction to who you are. So apologies for that. And
thank you.
Your name is much bigger than an introduction. Thank you very much.
Thank you very much for this nice introduction. I really appreciate it. Thank you. Good evening, everyone.
So I haven't even talked about the subject of your presentation today. It is going to be on the CGRP monoclonal antibodies and the role of CGRP monoclonal antibodies in the management of migraine. And of course, the floor is yours. I'm not sure if the presentation, are you sharing? Or not yet?
I already shared.
We still cannot see on our screens, Dr. Ammash.
I'm gonna try again.
Yes, please.
Okay, here we go.
Yes, we can see it now. Thank you very much.
Here we go. Good evening, everyone. Thank you for inviting me to be part of this lecture about migraine. First of all, let me tell you something very important before we get started and talking about migraine and the treatment. Things changed tremendously. The era where we used to treat migraine with 4 to 5 medication, one prophylactic, first analgesic, and if the first analgesic doesn't work, we go to the second analgesic. And when the second analgesic doesn't work, we go to the third analgesic. This is gone. This era is gone, and it's gone for forever. I hope so. Now we are having a new medicine. We are having even medicine that are with the same pill, we can treat the acute attack and prevent the recurrence of the migraine. So things change tremendously. What I will be doing in the next half an hour, the first part of this talk will be about migraine in general, just to familiarize you with the signs and symptoms, and then we'll be talking about this new medicine that we are having to treat migraine headache. This is the disclosure. First of all, migraine is one of the most common disease, and it's estimated that more than 1 billion people are affected with the disease all over the world. At a young age, the prevalence of the disease is the same between boys and girls. However, afterward and during puberty, it's more frequent in female. It's estimated to be 3 times more frequent in female than in men, and this is secondary to hormonal changes. However, with age, the prevalence will decrease in both male and female. Keep in mind that after menopause, a big proportion of those patients, their migraine will go away by itself. The prevalence of migraine in the Arab country is unfortunately not very accurate. It is estimated to be between 2.6 and 32%. And this is a big discrepancy between 2.6 and 32%. And the reason why we are not having correct numbers is because unfortunately we don't have an accurate data. However, it is estimated to be between that the 12.2% of patients with medical students are suffering from migraine, and that the majority of them are female patients. Migraine costs us a lot. Migraine has a huge economical, it is a burden on our society. It is estimated that the annual cost of migraine is between 50 and 111 billion euro in Europe. The mean average cost of migraine per person is 1,222 euro, which is a lot of money. Unfortunately, migraine is not only headache. Migraines are not only nausea or vomiting. Migraine is associated with a lot of comorbidity. And one of the most frequent comorbidity associated with migraine is insomnia, depression, anxiety, gastric ulcer, and GI bleeding. And this is why I said a few minutes ago that treating patients with migraine without taking into consideration the psychological part of the disease is useless. You have all the time to take into consideration the psychological status of the patient, if they have a depression or anxiety or insomnia or whatever, and to treat it at the same time that you are treating pharmacologically the migraine by itself. Otherwise, the success rate will be extremely low. This is a very interesting study that was done over 10 European countries, where they send a questionnaire to patients who are having migraine. The total number of patients was 3,466 patients, and it was distributed all over Europe. And this is, as you can see, the number of patients who seek medical attention for their migraine versus the patient who did not seek any medical attention. And in red are people who did not seek medical attention. And look how high it is. I mean, it's extremely high. And you see that the majority of patients suffering from migraine, unfortunately, do not seek any consultation from a healthcare provider. We can consider this in a country where there is no insurance, but how can we explain this in a country like France, United Kingdom, or Germany, where the health system is outstanding, where patients go to the doctors and they don't pay a penny and they can get their medication for free. And this is most likely because there is not enough awareness about migraine and the different type of treatment that they are available. How do we diagnose migraine? First of all, like I said, migraine is not only headache. Migraine, it's a complex disease which is associated with many signs and symptoms. It usually starts with a prodrome. Prodrome are combination of irritability, depression, difficulty in concentration, food craving, sensitivity to light, fatigue. You know, they are just edgy, restless, that last between a few hours to a few days. And then 30% of the patient, and only 30%, are having what we call aura. Aura is any focal neurological deficit that can occur before migraine. It can be aphasia, dysarthria, visual loss, numbness, motor weakness, anything, just anything that usually lasts between 5 to 60 minutes, resolved, and then we start having the headache. The headache of migraine is usually unilateral, throbbing pain. But if you have a patient coming with bilateral throbbing pain, it doesn't mean that he or she doesn't have migraine. But the throbbing part of the pain is very important. They have nausea. Some of them can have also vomiting. Not all of them. They have nasal congestion. They can have depressed mood. They have photophobia. They have phonophobia. They have extreme sensitivity to light, smell, and sound. This attack usually lasts between 4 to 72 hours. And then come the postdrome. The postdrome usually lasts between 24 to 48 hours, and the symptoms are quite similar to the prodrome. There are 4 types of migraine: migraine with aura, migraine without aura, episodic migraine, which is defined as being between 0 to 14 headaches per day, and the chronic migraine, which is more than 15 headaches per day for the last 3 months. Why this is important? It's important because all migraine can ultimately lead, if they are not well treated, to a disease called medication overuse headache or rebound headache. What is medication overuse headache? You know that the patient with migraine, when they have a headache, the first thing they do, they run or they rush to take medication. This medication lasts for help them for a few hours, then they have the pain again, and they go and take another pill. And it helps them also for a few hours, and then they take a third time pills. And this is increase in taking all those medication or the overdosage, if I may say so, of analgesic will induce a new type of headache called rebound headache, where the patient is having pressure pain. This is the worst headache that it can happen. They are extremely difficult to control. Why I'm talking about this headache? It's for one single reason. The new treatment that we are having, the Japan that we are having, like Rimageptan and others, we have noticed that the patients who are using this type of medicine do not have the medication overuse headache. Do we know why? Definitely we don't know why. This is an observational study, observational remark that we have noticed, that people who are being treated with Japans do not have medication overuse headache. Fortunately, medication overuse headache or rebound headache do not occur in everyone. There are some risk factor, if I can say so. It's usually female with low educational level, less than 50 years old. They are physically inactive. They have a lot of bad habits such as increased caffeine intake, alcoholic, smoking, metabolic syndrome. Those patient symptoms of medication overuse headache will be headache. The headache is a pressure-like pain, like someone is squeezing my head. They don't have nausea or vomiting, no photophobia, very rarely phonophobia. And they have also many other symptoms associated with the headache. They have muscle pain, anxiety, depression. Medication that have been held responsible for the rebound headache are tranquilizer, opioid, aspirin, ibuprofen, and triptans. Those medicine, if they are being taken in excess, will induce medication overuse headache. This is why the first question that you have to ask the patient whenever he's coming to see you with a headache, are you taking any analgesic? How many analgesic are you taking per day? Approach consideration. In fact, whenever we decide to treat a patient with migraine, we have to take into consideration two elements: the attack by itself, the intensity of the attack, and second, the frequency of the attack. So we have two types of treatment: the acute treatment that has to be taken as soon as the first sign appear. And this acute treatment has to have only one target, is to abort the attack as soon as possible and allow the patient to go back to their normal life. The preventive treatment has a different target, which is to decrease the intensity and the frequency of the attack. However, unfortunately, it has to be done by taking medication on a regular basis, which now changed. Those are the medicine that are being used in the acute treatment of migraine. I'm not going to go over them. Just the big drug classes are non-steroidal, antiemetics. Usually we use it for pregnant women, triptans, Japans, and ditans. Acute treatment are having many unmet needs, which are, those are the following. 43% of patients are having side effects secondary to the medication. 67 to 82% of those patients will have recurrence of their pain within 24 hours. Unfortunately, a big bunch of those patients will having tendency to have medication overuse headache. And it is estimated in the US, and in the US only, that 2.6 million patients with migraine headache cannot take acute treatment or take triptans because of the cardiovascular contraindication. From this, we can conclude that 15 to 25% of patients with migraine in the US may be eligible for a new acute therapy, that although triptans are recommended at the first-line pharmacotherapy for the acute treatment of moderate to severe migraine, only 37% of those patients in the research study use triptan, and this is probably because of tolerability, contraindication, and side effect, and 15% were current users. What we really need to know that we really need to consider novel acute treatment in patients with contraindication to triptans or who use or fail to respond to treatment to triptans for at least 2 oral triptans. And this is where the Japans will come. We'll talk about it a little bit later on after we finish about the preventive treatment. Those are the recommendation of the European Federation of Neurology and the American Headache Society. As you can see that CGRP antagonists are being now on the list. It's true that for the European Federation, we are more conservative, and we usually recommend it to be used after failure of the regular medication. However, in the US, it's becoming more open, and it's usually, unless there is an insurance problem, I know from several of my colleagues that whenever they have the chance to start a patient on CGRP antagonist as the first line of treatment, they do not hesitate. Those are the different classes of medication available as a prevention: beta blockers, ACE inhibitors, anticonvulsive, tricyclic, calcium antagonist. Unfortunately, all those medicines are associated with side effect. Fortunately, we are having now the CGRP antagonist. And in my opinion, and in my current practice, and in my belief that definitely CGRP antagonist within the next few years will be first-line treatment for patients with migraine. I believe they are already in some countries. When do we decide to treat someone with migraine? What we used to say in the past, that if your patient is having 2 or more attacks per month, that you have to go ahead and treat him preventively. However, let's assume that you have one patient only, and this patient is having an attack so bad that he or she has to lie in bed for 2 to 3 days. Would I tell her, no, you do not fit the criteria of taking preventive treatment because you are doing one attack only? Of course not. What I advise you to do, even if you have a patient who's having even one attack, but this attack is so bad that they are completely dysfunctional for a few days, to go ahead and treat them. You have also to take into consideration or to consider preventive treatment if those patients have contraindication to the acute or failed acute treatment, if they have any tolerability issue, or if they are having tendency to overuse acute treatment. The preventive treatment that we were having till now, I'm talking about before the era of the CGRP antagonist, we're having a lot of limitation. First, I just want to remind you that when you used to treat someone with antidepressant or beta blockers, the first thing that we're telling the patient, you have to be patient. It's going to take 4 to 6 weeks before the medicine kick in. Same things for topiramate. Keep in mind, I just want to remind you about the side effect associated with tricyclic, which is weight gain, sexual disturbances, fatigue. Remind you about the topiramate associated with dizziness and cognitive decline, the fatigue and sexual impotence or dysfunction associated with beta blocker. All those side effects do not exist anymore with the new treatment. Anyway, to set things straight, let me remind you about the target of the American Headache Society, where they said, if you want to use any medicine, the target of those medicine should be the following. The patient should have a rapid and consistent freedom from pain and associated with symptoms without recurrence. They have to restore ability to function as soon as possible. Minimum need for repeating dosage. We have to reduce healthcare resource use and to have minimal or little bit side effect. Let's talk now about CGRP antagonist. You know, CGRP antagonist, or the idea that CGRP antagonists play a role in the pathophysiology of pain in general, it's not new. In fact, for decades now, we have been noticing that CGRP level is increased in the blood and salivary gland in patients with migraine, cluster headache, chronic paroxysmal hemicronia, and even in rhinosinusitis. We have also noticed that whenever we are giving an exogenous infusion, we were able to trigger migraine in patients who are having migraine headache. And this led the researcher to look for CGRP antagonists that can decrease the CGRP level to see if it's going to help. And it turned out that it works, and it really works very well with very minimal side effect. However, CGRP also is not only for migraine, it has been also to have some cardioprotective action, and it can also help in the neurodegenerative disorders such as Alzheimer's disease. However, there is not enough data to share with you regarding the cardioprotective effect or about the Alzheimer's disease. So what I will be sharing with you now is the benefit of CGRP antagonists in the treatment of migraine. Those are the different CGRP antagonists available: erenumab, eptinezumab, calcanezumab, fremanezumab, rimagepran, and ubrogepant. Just keep in mind that rimagepant is the only one that has the FDA approval for prophylactic and acute treatment. Rimagepant, in fact, it's a small molecules that go and block the receptors. By blocking the receptors, they will induce some changes that stop the progression or stop the attack of migraine. In fact, by blocking these receptors, they will inhibit the vasodilatation without active vasoconstriction. They will inhibit neurogenic inflammation and inhibit exaggerated pain signaling. All this will happen without the vasoconstrictive effect of triptans. So we are reproducing the same benefit of triptans without the side effect. What's also interesting, like I have mentioned a few minutes ago, CGRP mechanism of action is not associated with addiction potential to medication overuse headache or rebound headache. One more time, why? We don't know why, and I guess no one knows why so far. All what we know that we have observed in many studies, and this is extremely good. This means that this medication, in general, this category of medication, patients are not prone to get addictive like triptan or any other opioid or analgesic. Let's talk now a little bit more specifically about rimagepant. This is the 203 study, I guess, 302 or 303, I honestly don't remember, 303. In fact, there have been 4 studies, 301, 302, 303, and 310 for rimagepant, and the 303 is a 75 milligram over oral disintegrated tablet, and this is the study that was behind the FDA approval. It was very nice, interesting study that was done. It's a double-blind placebo-controlled study for patients above the age of 18 who has more than 1 year history of migraine, and the onset was before the age of 50. They have more than 2 attacks and less than 8 attacks per month. And those patients were divided into 2 categories, patient getting rimagepant versus placebo. And they were giving a diary and asked them to keep a diary of the migraine attack, the severity, if they have any photophobia, phonophobia, or nausea. The primary endpoint of this study was freedom from pain at 2 hours post-dose and freedom from most worsening symptoms associated with migraine also at 2 hours post-dose. The 21 secondary endpoints that reflect safety and tolerability were also met in the study. These 21 secondary endpoints were mainly divided into 3 categories: early action, 2 hours effect durable, and tolerability. And those are the results. As you can see, there is a significant difference between patient taking rimagepant versus placebo in terms of pain freedom and in terms of being free from the most bothering symptoms. Also, for secondary endpoint, significant difference is 397 versus 295, where patients were pain relieved 2 hours after taking the medicine. What we can say that of those patients who achieve pain relief at 2 hours, 71% of them continue to experience sustained pain relief through 48 hours. And this is extremely important, which means that rimagepant not only will help now, but the benefit will last for at least 48 hours. And this is extremely important because this will help the patient to go back to their normal life as soon as possible and not to take medicine again. What is also very interesting is that when we look a little bit more in detail about the study, we have noticed that the pain relief in patients taking rimagepant can occur as early as 15 minutes after taking medicine. So your patient can still benefit or start feeling some benefit 15 minutes after taking Nurtec. And in fact, the majority of the patient were pain-free relief, or I'm talking about the patient who responded to medicine, where the majority of them were free of pain by 60 minutes. A big number of those patients returned to normal because the benefit from the medicine was sustained. And it was also interesting that not only pain, also nausea, vomiting, photophobia, and phonophobia was also relieved in this patient. And usually the most bothering symptoms, it takes a little bit longer than the pain to get rid of them. However, within 90 minutes, those symptoms were gone. You know that there is a lot of discussion, ongoing and still ongoing discussion. What's better? Why are we so excited about giving Nurtec or any other medication for acute treatment when we have been having triptans since the 90s? In fact, I believe that The era of triptans is gone. It's over. Now we are having medicine that they are safe, almost no side effect. Why would I have to run the chance to expose my patient to have any type of complications when I know that there's an alternative? So from this, they start the idea saying, okay, what is better? Is it triptans? Do the patient who are taking triptans respond better to rimatriptans? What about if they took triptans and failed? Do they still benefit from Nurtec? In fact, yes, indeed. This is the result of a study that was done, study 406, to check if the patient who never took triptans, who took triptans and benefit from triptans, who tried once triptans and failed triptans to control their headaches, or took twice triptans and the triptans failed to control their headache, do they still benefit from CGRP antagonist? The answer is yes. The answer is yes, and as you can see, that the people who taking rimatriptan from the naive had significant improvement compared if they failed, they did not fail, or even if they succeed with the triptans. If we compare rimatriptan to triptans, let me show you a few data or few information. Let me share with you a few information. Number one, like I have said, 15 minutes up to 60 minutes, maximum 90 minutes, headache associated with the most bothering symptom is gone. 2 hours effect, the majority of those patients, or it's estimated that 60% of those patients will be free from most bothering symptoms. They are able to function normally. They are free from photophobia, phonophobia, and from nausea with rimatriptan. However, 67 to 82% of patients who took triptans have recurrence of their symptomatology 24 hours later. Nurtec has a sustained effect that lasts between 2 to 24 hours, and that can last even longer, up to 48 hours, where those patients can go back to their normal life like nothing happened. What is interesting that the most common adverse reaction associated with the triptans, with Nurtec or rimatriptan is nausea. That's it. Sometimes dizziness. However, triptans are associated with hypertension, with all possible complications of vasoconstriction, and they are contraindicated in any patient with cardiovascular condition. The safety of rimatriptan has been now established by many studies, and the long-term study was done over 52 weeks, showing that Nurtec is an extremely safe medication. What about if we compare Nurtec to other CGRP antagonists that can be used in the acute attack? So far, we have 3 available: rimatriptan, ibrogepant, and lasmiditan. If we compare the 3 of them, we can notice that Nurtec works faster. In 15 minutes, those patients start feeling better, compared to 1 hour for people taking Ubrelvy, compared to 30 minutes for people taking Rivo. The benefit is 48 hours for Nurtec, 24 hours for Ubrelvy, and 48 hours for lasmiditan. The half-life of Nurtec is longer, and this is why it has better benefit. Advantage is that Nurtec you take only once. However, with Ubrelvy and with lasmiditan, you start by 50 milligram or 100 milligram. You wait 2 hours. If there is no improvement, you have to take another. Similar to triptans. All this are not present in Nurtec. In Nurtec, you take it once and only once. The side effect associated with rimatriptan is nausea, abdominal pain, and dyspepsia. They are similar to Ubrelvy. However, lasmiditan is more associated with sedation, nausea and vomiting, and paresthesia that is not present in Ubrelvy and Nurtec. If we do like economical studies or to check how the cost, and the benefit of those medication, we can notice that we usually need 1.4 pill per migraine to control the symptoms if we are using Ubrelvy, 1.35 with Rivo, and only 1 pill for Nurtec. So you see one more time, as we have mentioned, migraine has a huge impact on our society, economical burden. This is why we try always to cut or to reduce the expenses that is secondary to medication. What about in prevention? Like I had told you before, rimatriptan is the only medicine that is FDA approved for prevention and for acute treatment. This is another study around 700 patients where first 12 weeks were taking one tablet every other day versus placebo. They were allowed to use any other analgesic during this period. And then there was an extension, open extension that for an additional 12 months. And you can see that there is a significant difference in terms of monthly migraine days for patient taking Nurtec versus placebo. The baseline MMD was 10.3 in the rimageptan treated patient and 9.9 in the placebo control. After 9 to 12 weeks, there was reduction by 4.3 days in the patient taking rimageptan versus placebo. There was also a reduction in terms of migraine days per week, where this time we tried to check the reduction of weekly migraine day, and it's estimated to be 30% in patient taking Nurtec versus 9.4% in patient taking placebo. This is the long-term safety that I was telling you about it. What is interesting here is that we have noticed two things. First of all, the safety, not only safety in terms of nausea and vomiting, but also the fact that even after this long time or this long period of time, the patient still benefit from the medication. So the tolerance that we were facing with other medication is not present with rimageptan. What about the dual therapy? You know that we can use rimageptan dual therapy. What I mean by this, like give one tablet of rimageptan every other day per month. And then if they have any attack, they can take one extra tablet. The number of extra tablets that they can take per month is 8. So they have an average, like say 15 that they have to take for over 1 month plus 8. When we are using those together for what we call dual therapy, we have also noticed that those patients were having significant improvement in terms of controlling the acute treatment and the preventive treatment as well. 63% of patients taking Nurtec for the acute treatment had freedom from pain at 2 hours, maintained through 48 hours. Almost 50% of patients taking preventive treatment also has reduction in their migraine monthly day. What is also interesting that the CGRP antagonist has been showed to be effective in absenteeism and presenteeism. Let me just refresh your memory about absenteeism and presenteeism. You know, one way to evaluate patient performance at work is by the number of sick leave that they take or by their performance at work. And the number of sick leave they take is called absenteeism. And then the performance where they are physically present, however, they are not able to perform well, is called presenteeism. And this is very important to assess every time you have a patient with migraine, because this will affect their career. And when we know that migraine usually occur between 25 and 40 years old, where those patients are at the peak of their career, it's very important to take into consideration the work part. So CGRP antagonist has been shown to reduce absenteeism and presenteeism as well. Okay, now we have so many CGRP antagonists that we are start wondering what medicine are we supposed to take? Which one is better? Which one is the best for my patient? Let me make it clear for you. I can tell you that Aimovig, Emgality, rimagepant are the same. Rimagepant has similar efficacy. And when they compare rimagepant to adalimumab, it has the same. There have been, and this is, it's maybe just leak of information, that there was a study called the Challenge study where they compared calcanezumab versus rimagepant, and it showed that calcanezumab and rimagepant were equal. Keeping in mind that we have all this idea that calcanezumab is a relatively powerful CGRP antagonist. However, and we are still waiting for the official publication, we don't have anything official now. We know that they are equal. So basically what I can tell you that rimagepant has the same efficacy that Aimovig, adalimumab, Vyepti, or calcanezumab that are available. However, the advantage of rimagepant is an oral administration. There is no contraindication. almost no contraindication. The only possible contraindication is elevated blood pressure or any very recent heart issue. However, in general, there is no contraindication. The good part of it also that there is no wearing off phenomena with Nurtec. You know, wearing off phenomena, I mean by this, usually when you give injection, you have to give it every month. And a lot of patients, 25 to 26 days after taking the medicine, they start feeling that the pain is coming back because the effect of the injection start weaning off. This usually do not happen with Japan because the patient is still taking one tablet every other day. And a lot of patients doesn't want to take injection. They just don't want to hear about needle. Japan can be an alternative. They have to take it one tablet every other day, like I said. To end, let me just share with you some of the side effects. Nausea, vomiting, dyspepsia, and abdominal pain, but it's really very little and not statistically significant. The percentage of patients who discontinue this medication was less than 2.7%. This is a prescription, so we can give one tablet every other day for 30 days, and you can give at the same time one tablet when needed PRN for a total of 8 tablets. To end, let me just tell you what I told you a few minutes ago. Things changed. Now, the treatment of migraine is completely different from it was a few years back. Anti-epileptic, beta blockers, tricyclic, everything else, it's over. I think this era is over, and I hope it will never come back. Now we are having new medicine called CGRP antagonist. Those medication are extremely efficient. Those medication almost has no side effect, and I hope that we'll be having more and more in the future from this category of medication, and we'll have more and more data about the benefit of this medication. Thank you.
Thank you very much. This has been a very interesting presentation and very valuable. Can you hear me?
Yes, I can. I can't see you, but I can hear you. Oh, here we go. Okay, here we go.
I have a few questions. The first one is related to the onset of action. One of the questions is, how do you explain the quick onset of action of rimegepant, given that its half-life is almost 2 times longer than the others?
Oh, because it's small molecules, it diffuses very fast, and it works on the receptors. This is one of the main issue. Keeping in mind there is a lot of unknown yet regarding CGRP antagonists, like this history of medication overuse headache. So we still need a little bit of time. I mean, CGRP antagonist has been in the market for not more than 4 to 5 years. You know that yes. Nurtec has been approved by the FDA in 2020. Yes. So in fact, what I usually always tell my patient, I tell also resident and fellow guys, you have to take it easy on those medicine. We still need a little bit of time before we know more about them.
And I have a question around the use as an abortive versus the use as a preventive for rimegepant. Is there any, or do we know if using it as an abortive less frequently than every other day, is there any long-lasting preventive effects that we can anticipate in theory, at least?
I'm sorry, I didn't get the question.
If someone is using it 8 days a month, do you think in theory there is a potential reduction or residual preventive properties?
You mean that instead of taking it 1 tablet every other day, which is 15 tablets per month, if they take 8 tablets, if it's gonna help in prevention?
Only as an abortive, is using
they can, of course they can.
Would it actually prevent them from having another attack?
If you are taking only 8 tablets per month, this is not enough to prevent.
Okay.
However, I mean, if you are taking 8 tablets per month, it means that you are having at least 8 attacks per month, right?
Yes.
Which is a little bit difficult. I mean, why would you
Which
suffer?
means they need to be on a preventive, which means
Oh.
that they should be, no?
Oh, yeah, they should be taking preventive medicine. Otherwise, they will be suffering for nothing. In the 2023, I understand that in the past, we didn't want to take medicine because we didn't want to weight gain. I wanted to get pregnant. I don't want to have sexual disturbances. I don't want to be sleepy. I don't want to feel dizzy. I don't want to have memory disturbances. All this gone. Now we don't have this anymore. With the new CGRP antagonist, all those side effects are gone.
And what is specific to rimegepant that it can be both an abortive and a preventive? Why is this the only CGRP that we know that actually has both qualities? Is there something about the structure?
Yeah, this is the only CGRP that did enough. We have enough data and study that what has been accepted so far as a treatment of prevention and acute treatment. There is definitely ongoing now submission to the FDA for other drugs, and I'm sure there have been in the past, and they were not FDA approved. But the reason why rimegepant or Nurtec has both indication because the data and the result of the study were quite convincing in terms of benefit and side effect.
I do have a question asking you, it's outside of rimegepant, but based on your experience, Dr. Amash, what is the best treatment for migraine in ER?
In ER? This is a very good question. I still go for the old anti-inflammatory, intramuscular, all these but goldies, unless they can take one tablet of Migraine or injection of Nurtec of Migraine. This is what you can help. But I still as an acute, honestly, I'm still believe in all these method of giving anti-inflammatory, intramuscular or IV.
Well, in North America, we do not want people living with migraine in the emergency room. That's the last place you want them to be. The lighting is too high, the wait times are very long, it's very noisy, and a lot of times nobody can believe them. If you go to an emergency room and say, I have a headache, a splitting headache, most of the time people are put aside, and they're not even triaged, kind of, this can wait, nothing emergent basically about the case. So we want to keep them outside of the emergency room. But we do have cocktails that are, practitioners have been trying to find something that works fast. And I agree with you, we have IM, but we also add ondansetron, an antiemetic of metoclopramide. We also have magnesium infused. We do have different protocols that we try to employ, but in practice, people living with migraine should not end up in emergency room.
I can't agree more with you. I agree 100%. I know that, they will go and sit in the emergency room, and the headache will get worse. Better if they get treated locally or go see someone. It's definitely better. And this is where
prevention. If they are ending up in emergency room, that's an excellent prevention patient. Cortisone, corticosteroids for
very good question. I have very good question. Wow. Okay, I was waiting for this. I don't know. I never used it. As simple as this. I honestly never ever used steroid. I know there's a lot of physicians who did, and I'm getting this question 2 to 3 times per year, and I always say I don't know. I never give steroid to anyone with migraine. I should try it one day.
Well, there is
no data
controversy, right?
Yeah, there is not enough data about using steroids. But I guess some people reported in status migrainous that you can give steroids to see if it's going to help or not. Why not? But I never did.
The next question I have is around, you did show us these slides around which one to use. Which one do you choose? And we still have this issue in North America. It has to do with coverage, approval process. We have something called patient support programs. And this is also something that I guess is an issue still around the world, which is cost. Is there anything that makes it easier for us to decide on these new medications? Are there any head-to-head studies done? Is there anything that tells me if you start with this, you have a better chance of getting a response?
You mean between the CRP antagonist, the different class? No,
Yes.
no, there is no study. There is a like review data or review or what we call meta-analysis. I mean, where we're comparing study to study. But head-to-head study, there is the one that I told you about it, about the challenge study, the possibility that Lilly will, I'm not sure if Lilly or another company, I really don't know which one, saying that galcanezumab and Nurtec are having the same benefit. But we don't have, this is very unofficial and not even sure that it is true or not. But all what I can say that we know, as a matter of fact, by reviewing the data, that Nurtec, erenumab, galcanezumab are almost the same in terms of efficacy. And all will depend, in fact, on the patient preference. If your patient is needle phobic, I mean, you go ahead and give him tablet. If your patient come and tell you, I don't want to take one tablet every other day, you can go for the injectable form.
I know that during the latest American Headache Society meetings, there was this, I think one of the key opinion leaders was saying, when we got the injections and it was once a month, my patient said, what, am I going to take an injection once a month and my migraine is just going to go away? And then, of course, when we had the orals, they were like, are you telling me I don't have to poke myself? That this is amazing. And that tells you that there are preferences. There are differences possibly in how people perceive different modes of whether injection or oral or whatever. But we know that oral is easier to carry around. We know that oral is less, or at least there's also the infusion. So there are different ones that can be used, and that are the preference of the patient is one of them, but also convenience, as you said, needle phobia.
You know, this wearing off phenomena, which is the fact that the injectable form, either being intramuscular or intravenously, you know, the medicine is weaning off 4 to 5 days before. It's really bothering the patient, and I haven't been noticing this. This is why what I usually do, if they want to take the injectable form, I give them like whatever, erenumab 70 milligram once a month, plus rimageptan 1 tablet when needed. You see,
yes.
So it can, I mean, and this is my advice for whoever is listening to us. I think there is 923 patient participant, which is amazing. So the combination of injectable and tablets is extremely good. If your patient doesn't want to take 1 tablet every other day and say, I want to take 1 injectable, that's over. Yeah, fine. We'll do whatever the patient wants as long as it's going to help. But at the same time, you can give them the rimageptan or Nurtec 1 tablet when needed. So you avoid all the possibility of going into what we call wearing off phenomena and having their migraine recurrent before the due date of the next injection.
True. I see this all the time with my patients as well, where there's waning, the effect wears off, and then the patients are left with nothing. And they're told, well, and I love the idea of adding a GPAN. Do we know anything about the safety? Are there any concerns about combining an injectable CGRP monoclonal with a GPAN? Do you have any concerns from a practical clinical point of view?
Not at all. Not at all. I might have now around, I mean, I'm fortunate to work in a place where the insurance is not a big issue for my patients. And I have now a big number of patients, at least between 70 to 100 to 80 patients taking combination, injectable and tablets, and none of them have any problem.
And botulinum toxin, is that something that you also combine with these medications?
Yes, you can. It's very safe to combine botulinum toxin with GPAN, injectable form and the tablet form. Even it has been recommended, and there is a new data mentioning that the combination of both of them will have better result.
Well, in North America, we have the with Ubrelvy or Ubrogepant, the manufacturer is saying if you do not get relief within 2 hours, you can take a triptan. Do you encounter this also with Nurtec? Do you have
No.
patients both on a triptan and a Gepant?
Honestly, I rarely had to use triptans when I prescribe Nurtec to my patients. However, keep in mind that other CGRP antagonists, that the tablet you can take another tablet 2 hours later.
True.
Like
But
when you
then
take
if after 2 hours, they're still suffering. If it fails after
so you
the
have to go.
tablets, what do you do?
If there is no contraindication, you have to go with triptans. And if triptan doesn't work, you have to go to the injectable form to control the symptoms.
Okay, I think I have one maybe comment, not a question, around 75% of patients are not seeing a healthcare professional and getting treatment has not changed since the 1990s. A lot of people in the community are not really seeing a specialist. They're not seeing any doctors. They think it's just a headache and they kind of just sleep it off. Do you feel that this will change with these new medications that are coming? And is it going to be led by all the work that pharma brings to patient awareness? What are your views on patients' access to healthcare professionals with this condition?
Yeah, I honestly believe that there was 2 major reasons why people did not seek medical attention. First of all, because they had this idea that having migraine is a disease that will never be curable, and you have to live with it. You have to get adjusted to it. And the second, because they know about the side effect that they were present with the old medication. I'm sure that they had someone in the family who suffered from migraine and took any type of prevention and have a lot of side effect. But now with this campaign, with this, the drug company are being very aggressive in terms of marketing, in terms of increasing the awareness of the patient. And this is very good. I'm hoping that this is gonna help better and make things, push the patient to seek medical help more than it was before.
And I can see 910 attendees on our platform
fantastic.
tonight and attending this tonight. What as a specialist, we don't want everybody to come to you, right? We want people to be managed in the community as much as possible, and the cases that need specialist care to get to specialists. For these simple cases, what is your advice to nurse practitioners, pharmacists, and GPs that are attending today? What would you advise them to do when they have someone living with migraine?
Well, first of all, I mean, are you talking about in general approach or during an attack?
If someone comes in and they have an attack, how would you, let's start with that. If someone goes to the GP and they are talking about the attacks, what is the first line that you would ask them to, or what are the general advice that you would have them impart on their patients and prescribe for them?
All depends on the severity of the attack, of the intensity of the pain, and the severity of the most bothering symptom, which is nausea, vomiting. If those patients are having mild to moderate form, I try to give them something, simple, middle and strength. If it's a severe form and the patient is in severe pain, I have to send it, he or she has to go to the emergency room and receive injectable form to control their symptomatology. Once this is being done, afterward you'll have to sit and what's to avoid and what's to do.
I think you froze for a minute. I'm not sure if it was my connection or yours. Once, what happens? I'm sorry, I didn't hear that.
Your internet is unstable too. Can you hear me?
Yes, I can hear you.
Okay.
I just
so I was saying,
one part that I think was crucial.
No, I was saying that all will depend on the intensity of the pain. If it's mild to moderate and it can be handled in the clinic, I mean, the patient can receive any tablets and the patient can receive any intramuscular injection and go home. If the pain is very severe and they have nausea, vomiting, and they are crashing, they have to go to the emergency room.
Yes, and these are very, very few, right? Like
Right.
patients
Yeah,
that
very few.
end up
Yeah.
in emergency room is a very,
Very
very
little, very little.
small.
Yeah. We usually try to manage it in clinic. However, sometimes, unfortunately, if it's severe where they don't stop vomiting the whole time, they have to go to ER.
Okay.
Okay.
Is
But
there
you can, and sorry to interrupt you, in the clinic setting, there are different ways to handle this. If the patient can, what we can give them an analgesic, injectable analgesic, or we can give them triptans, or we can give them rimageptan and see how they will respond. All will depend on the intensity of the pain, and all will depend on the most bothering symptoms, the nausea and the vomiting.
And there's one question here around tinnitus and episodic and hearing loss. I'm not sure what the question is, but maybe I can ask about the use of rimegepant in vestibular migraine. Is this something that you also use in vestibular migraine, or do you use it because vestibular migraine is a little bit different with the vertigo and the symptoms being a little bit different? Do you feel that this is one of these treatments that you also use?
I'm not aware about any data regarding using rimageptan with vestibular migraine. All the data that we have been having so far are for migraine with aura and migraine without aura and the chronic migraine. But the atypical form of migraine, like hemiplegic migraine, vestibular migraine, and others, I do not believe that at this point we have enough data to talk about it or to give any recommendation.
Okay, and the question I have is, will the simplicity of this new therapy, the gepants and rimegepant, result in it being prescribed more in the primary care setting and by primary care prescribers?
Of course. This is the advantage, and this is why I tell everyone. I mean, rimegepant has to be prescribed by any non-neurologist because it is very safe, and this is why I try to say. To tell everyone. I mean, this is the difference between triptans, opioid, and the CGRP antagonist, regardless if it's a rimegeptan or not. The injectable form and the tablet form, they are extremely safe. They can be prescribed with by the GP or an internist. Rimegepant is even more safe because it's only one tablet every other day and one tablet when needed. So it's like giving any simple medication like Panadol or Tylenol or antibiotics. It's very, and no side effect. The only side effect is nausea, vomiting, and abdominal pain.
And are there patients that you totally avoid giving rimegepant? And is there any specific patient that you say, no, I cannot actually start this patient?
The patient who had the cardiovascular event very acutely.
And very recently as well, right?
Very recently, yeah. I'm sorry, I mean very recently. Those are the only category of patients.
Okay. And last words, I guess, what do you see in the future of migraine treatment? Do you have any view on how the treatment of migraine is going to evolve in the future?
I think this is the end of the tunnel, honestly. I see this is, I honestly, I'm very optimistic because I have been in practice now for 22 years, and I know how we used to treat migraine in the past. And you know, Hiba, how we used to treat migraine. I mean,
yes, I was.
yeah. You knew. I mean, you remember those prescription, the big prescription they used to write it. I mean, with 5 to 6 medication. Now it's over. I think this time is gone forever, and now we are having a new hope with this new CGRP antagonist. And I'm very optimistic. And I know, as a matter of fact, that there is different formulation. There is the nasal spray. There is a tablet of CGRP antagonist that's being worked on. So I'm sure that, I mean, it's the end of the tunnel, hopefully soon.
And I agree with you. I think the thing that I tell all my patients today is there's hope. Before we were saying, well, live with it, because we don't have a lot of tools in our toolkit. There's not a lot of medications that I can prescribe that don't have side effects. And these medications are changing this. They're making the quality of life better, and they're giving us hope that the future is going to be much better for people living with this condition. I loved your starting slide saying it's between 3% to 30% in our region, the prevalence. how sad is it that if you have a condition, on average, we're going to say 15% of everybody living did not have a treatment option that was tolerable, that was effective, that was safe. That is, as you said, this is, I don't want to say it's the end of the tunnel. I'm still waiting for the new targets, but what we have today is a great option for our patients. And thank you very much. I really appreciate it personally on a personal level, and I'm sure our attendees also appreciate this amazing presentation. Big thank you to our sponsor Pfizer for hosting this event for us, or for sponsoring this event, and of course the Association of Migraine Disorders in the US and IVPN NeuroPsychiatry. The resources are limitless and they're free on migraine management. So anybody who is interested in learning more, again, the future has never been or has never been brighter. There's everyday resources to help you manage this condition in your practice and support your patients, to give them a holistic treatment, as you said, psychology, psychiatry, and effective medications. Today is very bright already. So thank you very much for your time. I will hand over to...
I just want to say one word, excuse me.
Yes.
Yes, Hiba, thank you for being such a wonderful moderator. You were an outstanding moderator, and it was a pleasure sharing this session with you.
I really appreciate it. Thank you very much. Coming from you, Dr. Amash, I'm very, very
Thank
honored.
you very much. Thank you.
I will hand over to Maya, who has some announcements for the next events with IVPN Neuropsychiatry. I would like to thank everybody who has joined us tonight. You have been a great audience. Sorry if we were not able to get to all your questions. Join us on the next event and continue to support us and attend, and obviously support your patients by being the most knowledgeable on these conditions that we are offering you treatment options and education on. Thank you very much. Have a very, very good night.
So first, I would like to thank and echo Dr. Zakaria by thanking our amazing moderator and migraine expert, Dr. Hiba Bani, for always being with us, joining us, supporting us. And actually, Dr. Hiba played a major role in the success of the series of this webinar, contributing to the scientific program, and also facilitating the collaboration with the American Migraine Association, and leading and moderating this webinar. So thank you, Dr. Hiba, for all the support. Also, let me thank our speakers, Lindsay and Dr. Zakaria Amash, for a very comprehensive presentation on non-pharmacological and pharmacological management of migraine. Thank you for our sponsor, Pfizer, for supporting these educational activities. At the end of the webinar, I would like to say also thank you for you, our attendees. So we had today a very good attendance. Almost 1,000 healthcare professionals attended this webinar. So thank you for all of you for contributing to the success of this series. Also, I would like to remind you that you will receive your certificate of attendance by email within 1 week of today. And if you missed any part of this webinar or would like to revisit these amazing lecture, you can visit our IVPN library, which is available online, free of charge, and you can download and the recordings and revisit the webinar, this webinar, and all our IVPN neuropsychiatry activities. Also, don't forget to follow us and keep your eyes on our IVPN neuropsychiatry LinkedIn page, where we post all our educational activities, which are all free of charge and CME accredited. I invite you, if you are interested to learn about more about migraine, for our next webinar, which will be scheduled on September 6th, and we'll discuss also migraine. So stay tuned for more details, and until I meet you again, stay safe and have a good night. Thank you very much.